opportunities. So overall, in the last 4 years, about 4.8, I apologize for being small, but about 5% of urologist and TURP procedures are done by minimally invasive techniques. The good news is that if you follow in green, those numbers are increasing. I think in the next 3 to 5 years, because this is about 2-year-old data, there's benefits of this newer green light laser that I think a lot of people will get the opportunity for, and that'll be something that will be more prevalent in Canada. So green light itself, I'll talk to you a bit about it. What is it? It's light, it's energy. It's energy transmitted through water, which is absorbed by any red pigment. That's the special thing. It's a 532 nanometer wavelength. So it's kind of looking for anything that's got red. But when you hit the capsule, which is white and it's non-vascular, it kind of stops. That was what the issue with the TURP. It will just cut through like butter, like a hot knife through butter. It can cut through capsule, big veins, and so forth. This doesn't. And the initial ones didn't work that well because you had to work really close. That's what the graphic on the left shows, or on your right, shows that you had to work very close. And the next generation, in 2006, was the 120 watt. And this is the 180 watt, which we were fortunately the first ones in Canada. We little blurb in, I think, some of the newspapers last year. And simply what it is simply if I were to give you guys all sharp pencils and give you big Sharpies, you're obviously going to cover a page a lot quicker with a thicker mark. So that's one of the advantages. The laser lens, the glass itself, allows for delivery of 50% wider beam, and the power from 120 watts is 180 watts. I've been fortunate to treat almost 1,000 patients now with this, and I haven't done a TURP since 2004. Prior to doing this, and again, going back to the evaluation, we do what's called cystoscopy. Has anyone heard of a cystoscopy or had a cystoscopy? So a cystoscopy is simply a cysto for bladder and scope to look inside. There's 2 different types, and if you ever do need a cystoscope, you make sure you ask for the flexible one. Not all places have it, but for those, especially men, for women it's straightforward. It's usually a female has a short 5-centimeter urethra. It's not and it's a straight line. For a male, because of the curvature, to use a rigid cystoscope, to me, is very archaic. So at our center, we all have digital flexible scopes. And I think, one, it's flexible, it's smaller, it's more tolerable by the patient, and more importantly, it's digital, so that I think to get the patient involved in seeing what's going on, I think also helps in the delivery of care. So, so that's what we're looking for. So this first image here you can see is basically those kissing lobes, we call it, those lateral lobes of the transition zone compressing the urethra. At the same time, we can also pick up patients who have a stricture from a previous infection, instrumentation. Sometimes that is the reason they have these urinary symptoms. It's not their prostate. So these are other things to be picked up. And as well, some people have what's called a median lobe, a third lobe. Actually, so you have these 2 kissing lobes, you have this big ball which sits like a ball valve effect and blocks the urethra. And this is something else that doesn't respond well to medical therapy. And the condition of the bladder, sometimes we get it, and usually the bladder is a very smooth bladder, but if you have a bladder that looks like this, it looks like, this is your Arnold Schwarzenegger bladder. Something that's been having to push hard for years, and that's what we're seeing, those muscle striations, and it's compensation for the resistance. So if Mr. Cook and Mr. Sanders were going to be happy to remember that I remember my flow is related to pressure over resistance. So if resistance is increased, well, these are some of the factors which could do that. We do then do an ultrasound. I like to know how big the prostate is, because it helps me plan for surgery and as well relates to the PSA value. We published on this. I'll kind of jump through the technique. So simply what I'll do with the laser is treat the floor, treat the lateral lobes, and then you basically have this huge defect. So this is a patient before surgery. During the treatment, you can see relatively, this is just a still image of vaporizing through that top pink layer, which is the covering into the adenoma. So this is what the transition zone kind of looks like. It looks like kind of burnt cotton candy. And you saw that on the TURP, but here it's pretty much a bloodless procedure. You clear the floor, do the upper 1 o'clock incision, get this mammoth tissue, and then do the same thing on the other side. So this is what I'll do usually every second Thursday, about 6 to 7 cases like this, depending on the size of the prostate. This is one of the little videos I have on YouTube for my patients, kind of overviewing, so if they're going to enter surgery and so forth, some of the things to expect. I'll just play a little bit so you can understand. So simply during the treatment, you're going to see a lot of bubbles, and that's kind of what's happening. This glow of the beam, you're kind of looking at me and saying, well, I don't see anything green here, but this is through a lens, so it comes out at intense color. And that yellow glow you're seeing is ionization, the transfer of solid matter into a gaseous form. And what you can tell here is the speed at which it removes tissue and the fact that there's actually no blood vessels. There's no bleeding. So, and that's for that reason that we can simply use a smaller catheter, no irrigation, and get patients home that day. And at the end of the procedure, I usually do an ultrasound, and you can see now that there's this big cavity in the prostate. And that patient here, I just, for talks and so forth, we can see the before and after pictures and when it re-epithelializes. So these kind of guys are like blowing the porcelain off their toilet bowls, at 70, so, and they kind of wish they did this a lot earlier. But post-operatively, usually give them antibiotics for a week. Obviously, you're going to have some irritation symptoms, so I give them Motrin, anti-inflammatories, try to avoid narcotics. Up till about last year, we had something called Pyridium. Has anyone heard about Pyridium? It's a medication that sometimes turns the urine orange, but it's kind of an analgesic. It was used for some people who had infections and so forth. So that used to be given, we don't have that much anymore. And then one thing I tell everyone when we do this procedure, unfortunately, or fortunately, depending if you're a movie star or that's what you're into, but after this procedure, about 80% of men don't have antegrade ejaculation. So they'll have an orgasm, this won't affect your erections. However, you'll have a dry orgasm. The material will go the other way, and upon urinating, if you were to check the urine under a microscope, that's where the material for the ejaculate would be found. So I usually make sure that's clear in the younger guys who need this procedure. It's a busy slide here, but like anything else, any kind of procedure has risks of potential for bleeding, intraoperative bleeding, finding small vessels, 7 to 11%. This is the second generation in my series now. This is about 2 to 3%. Potential for urinary tract incontinence, less than 1%, depending on who's doing it. And these are all things I'll go through with the patient before delivering service. I guess maybe take a little pause. Any questions about enlarged prostate before I jump into prostate cancer?
What about the complication of TERP that used to be sexual dysfunction? Is there less of that?
That's a great question. There's been 3 studies. 1 that shows maybe, and 2 that shows no difference with green light. Part of the green light, I didn't go into too much physics details with you guys, but the depth of penetration is only 2 millimeters. So when you do this procedure, there's a 2 millimeter rind of tissue. Remember the picture at the 1 month photo, you can see some yellowish material. That's that sloughing material. When you do a TERP, there's a lot more thermal damage. You're bringing this metal loop up significantly, and especially, it's not just the cutting, because you notice we cut pretty quickly, but when you sit on each one with the loop and you cauterize, there's a much more broadened and blunt thermal damage. And that's the same idea when I do robotic surgery or any kind of prostate cancer surgery. It's all about the heat. And the heat is what damages these small unmyelinated fibers for erections. So to answer your question, is that what you're referring to by sexual dysfunction, erectile dysfunction? So yeah, green light, at least in 2 large studies, shows less of an impact, almost no difference. And I would say about 10% of my patients actually show improved erections. And why is that? Well, there's some correlation between BPH and ED. And for those who watch TV and see the new Cialis commercials, well, the daily Cialis is not only for erections anymore, it's actually for BPH. And I didn't put that up on the BPH slides, talking about Flomax, alpha blockers, but that's something else that could be used for that. And the second is because we're getting men off Avodart, and that has a big impact on erections.
BPH without enlarged prostate?
Well, the whole enlarged prostate is kind of like, it's a very broad term, it's kind of generic, So I've had men, when I do surgeries, the green light, where they have, like today I did one on a guy who was a 47-gram prostate. And I had another one 2 days ago, which is 187 grams. So it's kind of like hand sizes or my feet's large. Does that mean I have a problem? What's most important is that central tube and the kissing lobes. So does that answer the question? So yeah, I guess the answer is yes. You can have BPH without size matter. So
if there's a choice between taking medications such as Proscar, Flomax over long term versus the laser surgery, are there pros and cons one way or the other?
Well, I think anytime you do a surgical intervention, the nice thing about taking Flomax is that you stop, and any kind of side effect kind of stops. Surgery is kind of irreversible. And that's why I always like to make sure that we explore all the options, make sure the patients have tried. Some people come in, they've never tried it, or they referred for that. I'm always trying to not operate on someone. I want to make sure that they understand all the benefits, so that if they do the surgery, they understand everything. we made sure that's quite clear. So long-term, well, the long-term Flomax, no, there's no real risks of any of those alpha blockers. 5-alpha reductase, the Proscar and Avodart, well, there's some stuff now saying that perhaps the erectile function, sexual dysfunction may be permanent. So if you actually grab that Bible paper like that comes out like 8 feet long from each of your boxes of prescriptions, there's a litany of stuff, and if you actually go on their website, they have to post this. So you have potential sexual dysfunction, and possibly that if you're on these medications, the possibility that if you do have prostate cancer, it may be of a high grade. And that's kind of, is it true, is it not? It's not crystal clear. I think it's not a great thing for the medication. We're not giving it as much, and most people are coming to ask us questions. So those are those questions answered, I guess, for the medical therapy. And surgical therapy, well, there's always a risk when you do a TURP. Most people say it'll last for 10 years. Because a TURPs, people can do it, and again, I've seen some people coming back, and I'm just thinking 2 days ago I saw a gentleman who had a TURP about 2 years ago, and they came back because the symptoms came back. And it was like, well, why did this last? So I asked him to go to the hospital to get his operative report, the anesthesia report, and the pathology report. Why? Because the anesthesia report showed me it took the surgeon 19 minutes, and they only removed 5 grams. So when I went to scope the guy, he had a small little funding in the bladder, but those lobes were still prominent. So depending on, like anything else, it's not the equipment, it's the surgeon and their technique and all that I think plays a huge role in how people do in their outcomes. So that's a whole mixed bag of things, so it really depends on who's doing it. But in general, from the published literature, the green light or these types of minimally invasive techniques have the same parameters of uroflow, bladder, residual volume, improvements in quality of life, and appear to be as long-lasting as a TURP. Other questions? Okay, so we'll dive into prostate cancer. I think, starting the month of November, this is kind of a big topic for men. Prostate incidence, depends, is my answer usually. Well, do you live in Japan? Do you live in Saudi Arabia? Well, the incidence is not 1 in 6. If you live in Scandinavia, it's almost 1 in 4. So depending on where you live, is it because of the nutrients that we take, the sunlight exposure with vitamin D? We're not sure. Certain exposure to certain viruses or what have you, we don't know. But ultimately, in North America, the incidence we're looking at is about 1 in 6 men. The diagnosis is usually one of the things we talked about, rectal exam, nodule, PSA, kind of globally more than 4, or what we call PSA velocity, if it's going up fast or if it changes. And ultimately confirmed. No one can tell you have cancer until you do the biopsy. So unfortunately, it's not something you can't do without. With regards to that process, I don't know, has anyone ever here had, I'm not sure if you're shy to show it, but has anyone ever had a prostate ultrasound or a biopsy? So these, again, it's not the most pleasant thing in the world, and again, who's doing it also plays a role. In short, how I describe it to people and how to teach you guys, when I explain this is what we're going to do, usually we can't be on any blood thinners, we're going to stop that a week before. We give antibiotics a day before, the day of, and the day after to protect against certain bacteria, because this is obviously going from the rectum to the prostate. This is how it's done. It's called a TRUS, or a transrectal ultrasound biopsy. So it's a probe a little bit bigger than a finger that has a condom on top and a small tube, like a straw, that allows the surgeon to do 2 things. One, to use a very fine spinal needle to freeze both sides of the prostate. So we call a periprostatic block with xylocaine. After that, we take a series of biopsies. 20 years ago, we only did 6 biopsies. Now we do 6 small cores per side, so it's a total of 12 cores. We're looking at about 10 millimeters by about 1 millimeter size snaps. So because of the block, most people are doing that for the last 2-3 years, so I think for those who've had multiple biopsies, I'm not sure if anyone has, when they come and I remember having this 4 years ago, it really hurt, and we did it this time and it didn't have much of a difficulty. So, but those cores are then sent to pathology and they look under the microscope. And if you can think of a bunch of strawberries, okay, raspberries, I'm sorry. So the raspberries are those little circles with a hollow center. That's what the prostate is. It's a bunch of these glands that secrete in the center PSA and ejaculatory material. And the pathologist is looking for the architecture, and he's looking to see if there's cancer. And this is, for those who've had the diagnosis or know someone, we're looking at something called Gleason, the Gleason score. Well, what is Gleason? Any cancer, that breast, head, neck, whatever you have, or anyone has, they do two things. We need to grade it and stage it.